evening to all of you. So we have started with this bariatric surgery series. This is the second module, and of course, it is something that I do regularly. So who better to learn about it than me, right? So last week I gave you a little idea about obesity, bariatric surgery, in whom it should be done, what are the different conditions, how does one lose weight, what are the different options. So now let's start with core bariatric surgery. And today I will give you an idea of the different bariatric procedures. How did they begin? Kind of like the evolution. If you understand the evolution, how man thought about doing these procedures for weight loss and how it has evolved to what we do today, you will have a full picture and it will help you understand the subsequent sessions much better. It will give you an understanding of what this entire branch is like. It's a very interesting, very fascinating, and a very broad branch. What we see today is just a fraction of how it was before, right? So let me tell you how this bariatric surgery began and from where, and you will not believe what used to be done in the past. So last week I told you bariatric surgery means surgery for weight loss, right? It is a surgery done for weight loss, which came from the word baro. Baro means pressure or weight. So how did mankind start thinking about bariatric surgery? How did surgeons think that something needs to be done to make you lose weight? So how did it evolve? Initially, the understanding was very limited. They felt to do a surgery to make someone lose weight. Mind you, this is not liposuction. So don't confuse bariatric surgery with liposuction. There is no fat removal done here. What we are doing essentially is making the stomach smaller. If you make the stomach small, if the meal size reduces, every time you have a meal, you have maybe 20-30% of what you would eat normally. So you eat very less. And when you eat very less, you feel full because the stomach is small. That is the capacity. And you are consuming lesser calories. So thereby, by eating less, you are losing weight. This is called as restriction. So today, if you are able to eat, let's say, 2 chapatis with vegetable, with rice, with dal, with salad, the whole deal, a whole plate full of meal, after surgery, your stomach is made really small. How small you cannot imagine. Such that even if you eat, say, quarter chapati, half chapati, you are full. You will feel like you have eaten a full thali. So what surgery is doing in one way is reducing your meal size. But then they realized it's not enough because over time the stomach expands. So then they decided, let's give something stronger. Let's add some malabsorption. Means whatever you eat, some of it does not get absorbed in the intestines. So to do this, they started doing bypass. So they were bypassing the intestines. So if a normal person, let's say, has 5 meters of small bowel, they bypass 3 meters, 4 meters, so that the absorptive length remains only 1 or 2 meters. They bypassed it. Over time, they realize it is not just restriction and malabsorption. There are more mechanisms. There are neurological mechanisms, like there are hunger. Why does one feel hungry? It comes in the brain. There are hormones related to hunger. Then there are hormones in the gut, like GLP-1, glucagon-like peptide. This gives you some glycemic control. There are organisms in the gut which also have some role in obesity. There are bile salts which also have some role in obesity. So they realize it's not a one thing that controls your weight or your metabolism. There are a multitude of factors. Nowadays, they are realizing more and more factors which have a role in your weight maintenance. Some people who have extra weight, some people who suffer from obesity, they have a problem in these mechanisms also. Maybe their hormonal profile in the intestine is different. Maybe their bacteria are different. This has been studied extensively in literature. So what was happening was they started doing procedures, thinking some of these mechanisms would do it. And later on, they studied that a simple procedure had multitude of effects. So first they would do surgery, then they would understand the implications, something like a reverse surgical understanding. Try this, see how much weight he loses, then realize the effects, and then realize, oh, what went wrong or what can be done better. This is how it has been evolving. It is still in evolution. You will see when I take you through the different procedures, how much they have evolved, you will see, right? So How did the surgery begin? Of course, people were overweight 100, 200 years ago also. Surgeries were going on even at that time. Kings and queens, if they were overweight, they could not live very long. So to make them healthier, what could be done? The first procedure for weight loss, I would not really go as far as calling it a bariatric surgery, but the first procedure for weight loss, as shocking as it would sound today, it wasn't shocking at that time, was mandibular maxillary wiring. So what they would do is they would wire the upper and lower jaw together such that you can't really open your mouth. If you can't open your mouth, how are you going to eat? This was called as interdental wiring. Trust me, this was done some hundreds of years ago. So what they would do is for 2 months, keep the mouth nearly closed because of wiring, release it for 1 month, and repeat the cycle again. So there were so many problems with this. One is he can take only liquids. In those days, they did not know much about what supplements, vitamins will have to be taken, but he can drink only liquids. He can't open his mouth, so he cannot have solid food. Difficult to speak. May have been able to, depending on how much he was wired, but definitely a very mentally traumatic procedure. Yes, you do lose weight. If you're not eating, you will lose weight. If you're on liquids only, of course you will lose weight, but at what cost? It was weight loss would stop soon, oral hygiene, bad breath, and once you remove the wiring, he will start eating again. He will in fact start eating more because you have deprived him. So the problem with such kind of drastic procedures like jaw wiring or these, it could not be sustained in the long term. This was a few hundred years ago, but historically, this was one of the original procedures. So like this, they tried doing. Now we have an understanding of over 60 years. Truly bariatric procedures started in the 1960s, which I will start with from now. Initially, they were open surgeries. Now they are done laparoscopically. Like whatever procedures I do today, they're all laparoscopic. We don't do bariatric open. It's traumatic. It's very difficult because the abdominal wall in these patients are very thick. It's not like a normal laparotomy where it's a 2-inch abdomen. It's not. They have 5 and 6 inches of subcutaneous fat. So to go inside and do the surgery, it's like going into a well. Hard to imagine, but that's how it is. And of course, over time, safety has become better. Complications have become lower. Acceptance has improved. So a lot of people are upfront. You would be knowing there are so many celebrities who have had bariatric surgery. Some of them even openly say that yes, I've had a weight loss procedure. Some don't, but that's fine. Acceptance has improved. Outcomes, of course, has improved with the advancement in the technology. So these kind of procedures didn't really work much. Wiring and all. When did true bariatric procedures begin? The first procedure that they did was called a jejunocolic bypass. So what they would do is they would join early jejunum. So this is duodenum and this is the jejunum. So they would divide the jejunum early, bypass most of the jejunum, ileum, everything, and join it to the colon. So this proximal jejunum would be joined to the colon. And all of this then is bypassed. So whatever food I eat will go stomach, duodenum, jejunum straight into the colon. So obviously this will give you a massive malabsorption. So they originally began with malabsorption. The initial bariatric procedures were malabsorptive procedures. That's how they really began. Of course, with so much malabsorption, weight loss was dramatic. Patients would lose 10, 20, 30 kgs in the first month itself. But yeah, too much diarrhea, dehydration, electrolyte problems, hepatitis, a lot of things. Enterohepatic circulation of bile is affected. So the morbidity was enormous. They said this is too big a bypass, jejunum to colon. So they decided, maybe a little later, all this is happening in the 1950s and 60s. Let's make the bypass a little conservative. Don't make jejunum straight to join into colon. Maybe join it to terminal ileum so that the ileal absorption is intact. Ileum is the most important part of the small bowel. apart from nutrients and electrolytes, it is where your enterohepatic circulation happens. So bile salts go in terminal ileum. So fat absorption is terminal ileum. B12 is terminal ileum. So let's keep the terminal ileum intact and not bypass it. So the next what they did was called a jejuno-ileal bypass, where as you can see, proximal jejunum was joined to terminal ileum. But still, this was a very powerful bypass. As you can see, what they would do is they would count. This is the DJ flexure. They would count only 14 inches. So originally, they would take 14 inches of jejunum. 14 inches, that is nothing. That is maybe 35 centimeters, little over a feet, little over a foot. So 14 inches of jejunum was joined to terminal ileum of just 4 inches. 4 inches is 10 centimeters. So maybe 45-50 centimeters of absorptive bowel. What was their premise? Yes, we are keeping the terminal ileum intact. So they are happy. Yes, terminal ileum, yeah. That's all they did. So instead of joining it to colon, they joined it to terminal ileum, end to side. Over a lakh of these procedures were done in America alone at that time. And they would give a lot of weight loss, 80% excess weight loss. Excess weight loss means, let's say my weight is 100 kilos. And for my height, my weight should be 60 kilos for my height. So my weight currently is 100 kilos. But my ideal body weight, which is defined by what your height is 60 kilos. So how much is my excess weight? How much am I overweight by? I am overweight by 40 kilos. If I lose 30 kilos out of 40, that means my excess weight loss is 75%. If I lose all 40 kilos, my excess weight loss is 100%. So with these procedures, you could get 80% excess weight loss. Means out of 40, patient will lose 32 kgs. If he was 50 kilos overweight, he will lose about 40 kgs, which is amazing. It's a lot of weight loss. So yeah, these procedures were good, but how are they working? Malabsorption again. Right, malabsorption. So patients were, of course, losing weight, but they were not very happy. Electrolyte problems. There is such a big blind loop over here of jejunum, such a big blind loop. So there will be bacterial overgrowth and problems of bacterial overgrowth, blind loop syndrome. So much malabsorption, vitamin deficiencies were still happening. Stones were forming, both gallstones and renal stones, like you see in short bowel syndrome patients. So they were getting because of enteric hyperoxalemia. And yeah, a lot of patients died. In fact, in the 1970s and 80s, when they realized this procedure was having so many problems, they started calling each and every patient, telling them, come back, we will reverse it. So a time came where they reversed the procedure. They were like, forget it, it's not worth it. So problems were so much, they would intentionally call the patient and say, no, this procedure is not working, come back, we will undo it. So they would restore the normal anatomy. So bariatric surgery began. Basic problem was too much malnutrition. Diarrhea, protein, vitamin, stones, bacterial overgrowth, too many problems. So patients were like, I am happier being 40-50 kilos overweight. At least I am living like a normal person. Versus going to the toilet 10 times a day. Not worth it. So they said malabsorption is not the way to go. And then they stumbled upon some other procedures. This was one of the original bariatric procedures given by a doctor called Nicholas Scopinaro. He recently died last year. What he did was, this was a kind of a gastric bypass. It was like a gastric bypass. So what he would do is, he would divide the stomach into a proximal half and a distal half. Distal half he would bypass. So distal stomach, duodenum, jejunum, he will bypass. He would divide the ileum and join it to the stomach. So what he is doing here is a gastro-ileostomy. So this is a fairly small stomach, compared to a normal stomach. So this was the first time stomach was worked upon. So you will eat a meal, small meal, it will fill the stomach, then it will go straight into the ileum. So of course there will be some amount of malabsorption, some amount of restriction, but this was mainly malabsorption. Mainly. So this procedure was doing well for a long time. This was called the iliopancreatic diversion.